Hi everyone, I'm Dr. Marivic Garcia from the section of cardiology, and this morning I'm going to teach you how to read abnormal ECGs. So we have learned that we can use the ECG to look for rhythm abnormalities as well as ischemia and infarction, chamber enlargement, and other miscellaneous disorders like electrolyte abnormalities. But today we're going to talk about rhythm abnormalities as well as ischemia and infarction. We know that the SA node is the primary pacemaker cell, and it is found between the right atrium and the superior vena cava. Once it depolarizes, it will depolarize first the atria, producing the P wave in our ECG. After which, the wave of depolarization will be received by the AV node, where it will stay there for some time, producing the PR segment. Thereafter, the wave of depolarization will travel down both bundles to the Purkinje and eventually the ventricles, depolarizing first the septum, producing the Q wave, eventually the rest of the ventricles producing our RS. So once we see the QRS, we know that we have depolarized both ventricles. And eventually, we will see the T wave, which tells us that the ventricles have been repolarized. We need to remember normal values. So a normal P wave in duration should not last more than 0.10 seconds and should not be more than 0.25 millivolts or 2.5 small squares in height. The PR interval should be from 0.12 to 0.20 seconds. The QRS should be from 0.06 to 0.10 seconds. The QT interval should be from 0.30 to 0.40 seconds at a heart rate of 60 to 100 per minute. Now, in a regular rhythm, we get the rate by using this formula, 1,500 divided by the number of small squares. Or we can use 300 divided by the number of big squares. We have also learned that we can use this shortcut, 300, 150, 175, 60, and 50. So we just remember 300, 150, 100, 75, 60, and 50. In case you see irregular R to R interval, so we get a 3-second strip and we count the number of complexes within, multiply it by 20, and we get our rate in minute. So this is a 3-second strip. So 6 times 20 is 120 per minute. Or if we have a 6-second strip, then we multiply the number of complexes we see within times 10. So when do we say that we have a normal sinus rhythm? So we look at the P waves. So the P should appear regularly at the rate of 60 to 100 per minute. If we look closely, the cycle length or the intervals between the complexes should not vary by more than 10%. The PR interval should be from 0.12 to 0.20 seconds. If we look at the same lead, we should see exactly the same contour of the P wave in the same lead. And the P should be upright in 1, 2, AVF, and the left precordial leads V4, V5, V6. And the P should be followed by a QRST complex. Let's look at this ECG tracing. So we see regularly occurring P QRST complex. So if we get the approximate the rate, so this is 300, 150, 100. So this is between the 100 mark and the 75 mark. So we know that we have a normal sinus rhythm here. Now, how about this one? We see regularly occurring P QRST complex. However, if we look at the rate, so this is 300, 150. So this is no, between 150 and 100. So we know this is more than 100. So this is sinus tachycardia. While here, we see regularly occurring P, QRST. But if we get the rate, so this is 300, 150, 100, 75, 60. So this is between 60 and 50. So here we have sinus bradycardia. Okay, when do we say that we have sinus arrhythmia? If you will look closely, no, at a glance, you see that the R to R interval are highly irregular, but you see exactly the same P for every QRST complex, and the P appear the same on this lead. No? So that means this is still sinus, but the difference between the shortest, okay, and the longest interval here is more than 10%, or that is more than 0.12 seconds. So this means we have sinus arrhythmia. Let's go to supraventricular arrhythmias. Here, you can see that this complex appeared earlier than the distance between this one to that one. So this is a premature complex. If you look at the P waves, the P here, no, this is different in morphology to the rest of the P waves. So you know this did not come from the SA node, but it came from somewhere in the atria that was able to depolarize the atria ahead of the firing of the SA node. And it was able to be conducted to the ventricles, producing a QRS, no, T after the premature P. So this is a premature atrial complex. Now, if you will look, no, if you will evaluate this tracing, so this is PQRST, PQRST at the rate of, so this is 300, 150, 100, so around 75 beats per minute. But on the fourth complex, there was a premature beat that came and was followed by a series of QRST complexes. The QRST complex is narrow, okay? It is narrow, but if you will check, there are no P for every QRST complex. So when you see like this one, no, where you have a regular narrow QRST complex without a P at a rate of, if we will get the rate here, so this is 300, 150, so this is more than 150. Okay, so at a rate more than 150, but the QRS is narrow and there is no P, so this is supraventricular tachycardia. So a clue here is if you see that the QRS is narrow, you know that that complex came from above the ventricle. Okay. How about this one? So in this case, we see PQRST, PQRST, but if you will, at a glance, you see that the distances or the interval are different. No? So this one is shorter, this one is longer. And if you will look at the P waves, there are different P waves here. This is different from that one. This one is different from this one. But each P is followed by a QRST complex. So that means that this came from a different site to this one, no? And this came from a different site again from this one and this one. So that means that you have a wandering atrial pacemaker. So in wandering atrial pacemaker, the rate is still within 60 to 100 per minute. Now, here, again, we see an irregular R to R interval, but there is a definite P for every QRS complex. Now, if we will check, this P is different from that one. And this one, okay, is different from this one because this one is has a shorter PR interval than this one. Okay, so this came from a different focus again. And again, this one is different, no? So this is one and one P, this is another P, okay? This is a different P, a third P, and this is a fourth, no? P, no? So if you have at least 3 different foci in the atria and your rate is more than 100, so then this is called multifocal atrial tachycardia. So this is like a wandering atrial pacemaker. The only difference is that the rate is more than 100, ventricular rate is more than 100 per minute. Okay, about this one. So here, okay, you see that there are a lot of P's, okay, for every QRS complex. So if we will get the rate here of the P, okay, so a P to the next P is the atrial rate, no? So you are getting the atrial rate. So if the atrial rate here, okay, is from 200 and above, okay, and followed by a QRS complex. So the QRS, you can see it as irregular, R to R, or you can have a regular R to R where you have a fixed, no, block. So this is what we call atrial flutter. So here, these are the flutter waves, no, where it assumes a sawtooth appearance. So here in atrial flutter, this results from a single, no, reentrance circuit around a functional or a structural barrier, no, within the atria that is conducting. So depending on the block in the AV node, so if you have a fixed AV block, then you will have a regular R to R interval. So this is what I was telling you about. In atrial flutter, no, you see the sawtooth appearance of the P waves. No? So it's like the tooth of a saw. Here in this ECG, we see regularly occurring QRST complex. No? So we know that if you see a regularly occurring complex, that it is coming from a pacemaker cell. Now, if you will look closely, the QRS is narrow. So we know that this came from above the ventricle. But there is no P before the QRST complex. Okay, so no P. So we know this is not sinus in origin. But we see an inverted T following the QRS complex. So what happened here is the SA node did not fire, and what is the next pacemaker cell is the AV node. So the AV node will fire at 40 to 60 per minute. So if the AV node fires, the wave of depulsation will be conducted to both bundles. So you still have a facilitated transmission, no, to both ventricles, so that the QRS complex will still be narrow. Now, sometimes the wave of depolarization is retrogradely conducted to the atria, depolarizing the atria. And if that happens, you will see a P that is inverted. So it can occur just before the QRS or just after the QRS. So this is a junctional escape rhythm. So let's go to ventricular arrhythmias. So in this tracing, we see this wide QRS, a wide, bizarre-looking QRS complex with a T that is opposite in deflection to the main QRS complex. Now, if we will look at the QRS, there is no P before the QRS. So we know that this did not come from the SA node, okay? Nor did it come from the atria, because if it came from the atria, it should have a P before the QRS complex. Okay, this did not come from the AV node, because if it came from the AV node, then the QRS should be narrow. But we see here a wide, bizarre-looking QRS with a T, or a T that is opposite in deflection. We call discordant T, with no P before that. No? So this is a premature ventricular complex. Now, if we see the PVC, no? Uh, two PVCs, one after another, so consecutive two PVC, then we call that PVC in couplet. If we see the PVC alternating with a normal beat, like this one, normal, PVC, normal, PVC, normal, PVC, then this is a PVC in bigeminy. On the other hand, if you see the PVC, okay, after every third beat, so this is PVC, and then 1, 2, third beat, another PVC. So this is a PVC in trigeminy. And if you see the PVC every fourth beat, so meaning PVC 1, 2, 3, fourth beat, another PVC. So this is a PVC in quadrigeminy. Okay. And if you see on the same lead that one PVC is upright and another PVC is negative, then you know they came from a different focus, no, different foci in the ventricles. So this is a multifocal PVC. Now, sometimes the PVC occurs on the T, no, on the T of the normal complex. So, if the PVC occurs on the T of the normal, no, complex or the sinus bit, then that is an R on T phenomenon. And this is very dangerous because we have learned that the T, no, is the time when our ventricles are repolarizing already and therefore is easily excitable. So that if the PVC, no, occurs during the time that the ventricles are already repolarizing, then you can trigger, no, a fatal arrhythmia. So let's review. So we have learned that this is a PVC because it's a premature beat. There is a wide, bizarre-looking QRS with a discordant T, okay, with no P before it. So this is a premature ventricular complex. And we see here that the PVC is occurring, no, after alternating with a normal beat. So we call this PVC in bigeminy. Now, in this third, no, second, no, or middle tracing, we see the PVC after every on the third beat. So this is a PVC in trigeminy. And the last, no, we see the PVC on the fourth. No, every fourth complex is a PVC. So this is a PVC in quadrigeminy. Okay, so what is this again? So we have learned that when they occur side by side, then this is a PVC in couplet. Now, let's proceed. So here we see again regularly occurring QRST complex. Okay, but there is no P before the QRS. If you will look at the QRS, it is very wide and bizarre with a T that is discordant or opposite in deflection. So we know that if the QRS is wide, okay, and the T is discordant, that this came from the ventricle. But we see it regularly occurring. So that means this is coming from a pacemaker cell. So remember, SA node will fire at 60 to 100. AV node will fire at 40 to 60 per minute. No? And your His Purkinje can fire at 20 to 40 per minute. So this must be coming from the His Purkinje cell, no? His Purkinje system. The QRS here is wide. So that means that this came after the bundles have after the common bundle, no? Because there is already a delay in the depolarization to both ventricles producing a wide QRS. So if we will measure, no, we will get the rate here. So this is 300, 150, 100, 75, 60, 50, 40, no, 30. Okay. So this is a little over 30, so around 34, 35. So this is a what? So this is an idioventricular rhythm. Okay. Now, let's proceed. So here we again see the wide QRS, no? The wide QRS complex regularly occurring with no P before it, okay? But the difference is if we get the rate, so 300, 150, 100, so this is around 88, no? But we see the same, no, like the idioventricular rhythm. It's just that the rate is faster than 40. And we know that the His Purkinje can fire at 20 to 40 per minute. So this is faster than the usual firing rate. So we called it this accelerated idioventricular rhythm. Okay. So let's look at this tracing. So we have learned that if the PVC occur, no, side by side, two PVCs occur one after the other, we call this a PVC in couplet. So what about this one? We see four consecutive PVCs. So do we call this a quadruplet? No. So this is called ventricular tachycardia. But since it is just four beats, then that is non-sustained ventricular tachycardia. So when do we say that we have ventricular tachycardia? If you have at least three consecutive PVCs, okay, then that is already considered ventricular tachycardia. So that means that if we go back again, no, so atrioventricular rhythm is like, no, a PVC occurring one after another. It's just that the rate is 20 to 40 per minute. If we increase the rate, no, to more than 40 but less than 100, then we call that accelerated atrioventricular rhythm. But if we increase the rate further to more than 100, then we call it now ventricular tachycardia. So what are the different types of ventricular tachycardia? This is non-sustained ventricular tachycardia. So you see here, this is normal, okay? And all of a sudden, the patient went into ventricular tachycardia. Or you can see it continuously, so you call it sustained. Now, if the form, no, morphology is the same, so you call that monomorphic, no, ventricular tachycardia. Okay, if they change, so you call that polymorphic ventricular tachycardia. And if you see it, no, like this is up and then it goes down like this one, so this is torsade de pois. So it is better seen here. Okay, look at this one. Here, the PVC occurring one after another, so you call it ventricular tachycardia because the rate here is less than 300 but almost 300, no, so this is around 250, no, so this QRS is negatively oriented. And look at this one, and now it becomes positively oriented, and again it will become negative, and then it will become positive. So it's like it's twisting, no, so that's torsade de pois. And here, if we got an ECG before this happened and we saw that the QT interval is prolonged, then we need to give the patient magnesium. So that's the treatment of choice for torsade de pois because of a prolonged QT interval. Okay, now we'll proceed. Now here we see an ECG tracing with no definite complex. It's just an irregular undulation, no, of the baseline. So this one is coarser, this one is finer. So when you don't see definite T nor definite QRS complex, then you call that ventricular fibrillation. And ventricular fibrillation is the number one cause of sudden death. So if this is true ventricular fibrillation, then the patient is arrested. No? So all ventricular fib are arrested. Let's go to heart blocks and pauses. So imagine a scenario where your SA node will not fire. Okay, so therefore, do you expect to see a P wave? Of course not, because there will not be anything that will depolarize the atria. How about the QRS? If nothing fired, no, your SA node did not fire and none of the subsidiary pacemakers fired, then you don't expect to see also a QRST complex. Okay, so what do you see? You just see a line, no, a flat line. Okay, so there is no P here, there is no QRST complex. So you know that the SA node nor not the other pacemaker cells did not fire at this time. So you call this a sinus pause or a sinus arrest. Okay, so let's go to AV block. We have learned, okay, that the PR segment is the time when the wave of depolarization, no, stays in the AV node for a brief period. So we call that the absolute refractory period. Okay, so during this time, The atria have been depolarized, producing the P, okay, but the ventricles has not yet depolarized. That's why you don't have yet the QRS complex, okay? So any problem in the AV node will be seen on the PR segment. So in first degree AV block, what happens? What do you see? The SA node will fire. So it will depolarize the atria, producing a P, okay? But there will be a delay in the transmission to the ventricle. So what happens is that the PR segment lengthens. So that if you get the P to just before the QRS, you call the PR interval, then the PR interval will be prolonged. And what is the normal PR interval? It is supposed to be from 0.12 to 0.20 seconds. So if the PR interval is more than 0.20 seconds, but it is eventually followed by a QRST complex, then that is a first degree AV block, like this one. So here we see this is the start of the P, okay, and that is the end of the PR segment. So if we get one big box is 0.20 seconds, so this is more than 0.20 seconds. So this is first degree AV block. Okay, let's go to second degree AV block. So in second degree AV block, you have type 1 and type 2. So type 1 is also called Mobitz type 1 or may also be called Wenckebach, while type 2 is called Mobitz type 2. There's no Wenckebach type 2. So let's go to second degree AV blocks. So in second degree AV block, what you will immediately see is that there is a gap, okay, between the R to the next R. But within the gap, you see a P without a QRS complex. So if you see a P without a QRS complex, you know that you have a second degree AV block. Okay, so just to clarify, to differentiate this from an SA sinus pause or sinus arrest, there is totally nothing here in a sinus pause. You just see a flat line, but here you see a P. So that means you were able to depolarize the atria, but the wave of depolarization was not conducted to the ventricles. So when you see a P without a QRS, you know you have a second degree AV block. Okay, let's go to the two types of second degree AV block. In this tracing, okay, so PQRST, PQRST, okay, and then we see a P without a QRST. So we know that we have a second degree AV block. If you will measure the PR interval here and compare that to the next PR interval, what do you notice? The PR interval is prolonging until you see the P without a QRST complex. So an easier way to do that, to analyze the your tracing is the look at the complex before the drop QRS. Get the PR interval. So this PR interval is 0.28 seconds. Okay. If we compare this PR interval with this PR interval, which is just 0.20, this one is longer compared to the bit after the complex after the drop bit. So this is Mobitz type 1 or Wenckebach. Okay. So here we see PQRST, 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 and then we see a P without a QRST complex. So we know this is a second degree AV block. If we will check the PR interval before the drop bit and compare it with the PR interval after the drop bit, we notice that this one is longer than that one. So this is a second degree Mobitz type 1 or Wenckebach. Let's go to Mobitz type 2. So again, we see a P without a QRST complex. So we know this is a second degree AV block. No? But if we get the PR interval before the drop beat and compare it with the PR interval after the drop beat, they are exactly the same. So if the PR interval is fixed, okay, and you just see a P without a QRST complex, then that is a second degree AV block Mobitz type 2. Now, here we see two P's, okay, for every QRS complex. So again, we know that this is a second degree AV block because we see a P without the QRS complex. But there is two P's for every one that is conducted, no? So this is a 2:1 AV block. If you see at least three P's for every QRST complex, then this is considered a high-grade AV block already. So at least 3 P's for every QRST complex, high-grade AV block. Okay. So are you confused? No, I don't think so. Okay, so review again. So SA node will fire depolarizing the atria first, producing a P, after which the wave of depolarization will go to the AV node and then to the bundles, to the Purkinje, depolarizing the ventricles, producing our QRS complex, and eventually the ventricles will repolarize, producing the T wave. So in third degree AV block, we also call this complete atrioventricular block or complete heart block. Here we have an impulse coming from the SA node that will depolarize both atria. So since the SA node is a pacemaker cell, it will produce regular depolarization of the atria. So you see regular T waves. Okay. Now, however, the wave of depolarization is not conducted to the ventricles. Okay, so what will happen is that the ventricles must be paced by other pacemaker cells. And you know you have your His-Purkinje system. So your His-Purkinje system are also pacemaker cells. They are capable of firing. The only difference is that they fire at a slower rate from 20 to 40 per minute. So if the pacemaker comes from above, here, the common bundle, then you can still see a narrow QRST complex at a slower rate compared to the firing of your SA node. But if the pacemaker came from after the branching of your bundles, then you will see a wide QRS complex, but they will occur regularly. Okay, so in this tracing, the atrial rate is 80 beats per minute. Ventricular rate is 43 beats per minute, so it is lower, okay? And you do not see a P that is related to the QRST complex. So these are examples of, of complete heart block. In the first tracing, the red tells us where the T waves are found. The blue lines tells us our QRST complexes. No? So we see regularly occurring QRST complex. We see regularly occurring P waves. Okay. You see more of the P than the QRST complex, and none of the P is related to the QRST complex. Okay, so this is complete heart block. But you notice the QRS is narrow, meaning that this came from above the bifurcation or suprahischian. In the lower tracing, you again see more P's than the QRST complex. Okay, but the difference is the QRST here is wide. So that means that the wave, the subsidiary pacemaker, okay, that is pacing the ventricles is coming from after the bifurcation of our bundles. Let's go to bundle branch block. we have learned that the bundles, the left and the right bundle, will facilitate transmission to both ventricles. Okay? So that the normal QRS complex should only be narrow. It should not be more than 2.5 small squares. But in instances where there is a block, no, in one of the bundles, either the left or the right bundle, then the time it would take to depolarize both ventricles will be longer, prolonging the QRS complex. Okay, so if you see a QRS that is wide, no, that is at least 3 small squares or 0.12 seconds, okay, then that means that you have a complete bundle branch block. Now, how do you differentiate a right from a left bundle branch block? We look at V1, okay, and we look at V6. In V1, you see the RSR pattern. Okay, so R, it can be all small letters, meaning no, you just see small complex. So you have the rabbit ear. Okay, and at V6, you see a wide slurred S, like this one, a wide slurred S. Sometimes you can see it extending to lead 1. Okay, so that is complete right bundle branch block. In incomplete left bundle branch block, this time, what you see is a wide QRS complex again. So at least 3 small squares. But in V1, instead of seeing the RSR that we saw in the right bundle branch block, in the left bundle branch block, you see an like this one, a QS pattern, or sometimes you see just a small R and a deep S. Okay. In V6 and lead 1, you see a notch R. Okay, a broad notch R. You can also see this in lead 1. So if you see this, this is complete left bundle branch block. Okay, like this one. So you see a very deep S, a wide QRS complex, okay, in V1. And in V6 and lead 1, you see a notch, okay, a notch R in V6 and lead 1. Now, let's go to STT changes. We have learned that if we see abnormalities in this ST segment and the T, then we look at contiguous leads. So if we saw abnormalities in lead 1, then automatically we will evaluate AVL for the lateral wall. 2, 3, and AVF are contiguous for the inferior wall. V1 and V2 are contiguous for the septum. V3 and V4 are contiguous for the anterior wall. And V5 and V6 are contiguous for the lateral wall. So here, so V1, if you see abnormalities in V1, look at V2. So that is septum. V3, look at V4 for the anterior wall. So if you see abnormalities here, this is anterior wall. Okay. Now, V5 and V6 is for the lateral wall as well as 1 AVL. And 2, 3, and AVF are for the inferior wall. So let's practice, okay? So look at lead 1 here. So do you see any abnormalities? So it's okay. But if you look at AVL, there is a slight ST elevation here, okay? So, but then you don't see it here in lead 1. So this doesn't count. If you look at lead 2, there is a downsloping ST segment in lead 2 as well as lead 3 and AVF. So here you have an inferior wall ischemia. Okay. Now, how about this one? In V1, you have an ST elevation that you see also in V2, in V3, in V4, up to V5, but you don't see it anymore in V6. So this is an anterior wall ST elevation myocardial infarction. So if you have an ST elevation with an ST depression, okay, what is worse is the ST elevation because that is a transmural myocardial infarction. So This will be read as an anterior wall ST elevation myocardial infarction. The downsloping ST depression that you see in lead 2, 3, and AVF may be read as reciprocal changes, or what is the reciprocal of an elevation or is a depression. So this is reciprocal changes, or this can already tell you that there is ischemia over the inferior wall. Okay. Let's look at another tracing. So lead 1, so you have a flat T, AVL, you have a flat T. 2, 3, and AVF also shows you just a flat T. But if you look at V1, we have learned that in V1, you may have an inverted T, okay? But if you see it extending here, so here you have an ST depression with the T wave inversion in V2, in V3, in V4, in V5, up to V6. So here you have an anterolateral wall ischemia. Okay. How about this one? So here V lead 1, you have T wave inversion. So immediately look at AVL. So you also have T wave inversion. So this is lateral wall ischemia. But this one, lead 2, lead 3, and AVF. So no STT abnormalities. Okay. V1, you have T wave inversion, but you also see it in V2, in V3, in V4, in V5, and V6. So you have, this one is septum, this one is anterior wall, this is lateral wall extending up to here. So this is an anterolateral wall ischemia. Okay, so let's practice. Okay. Now look at the first tracing. So you see regularly occurring PQRST, okay, the same morphology of the P waves. But if we see, so we know this is sinus. If we get the rate, this is 300, 150, 100, 75, 60, 50, 40, 30. So this is less than 30. So this is sinus bradycardia. Okay. But this one, so we see regularly occurring PQRST complex, but this time the rate is 300, 150. No, this is more than 100. So this is around 110 or 115. So this is sinus tachycardia. Okay, but this one, so at a glance you see an irregular R to R interval, but there is a P for every QRS complex. Okay, so if the interval varies by more than 10%, then you call it sinus arrhythmia. Okay, so this is sinus arrhythmia. Okay, how about this one? So we see regular, narrow, complex, QRST complex. Okay, no P before the QRST. And the rate is more than 150. So this is 300, this is 150. So this is around 200 plus, no? So this is supraventricular tachycardia. Oh, this one. So we see, no, regular QRST complex. The QRST, no, the QRS is very wide. The T is opposite in deflection. Okay, if we get the rate, so the rate here is 300, 300, 150, 100 there. So it's very near 150. So this is around 140 with a wide, bizarre looking QRS, discordant T. So this is ventricular tachycardia. So here we see the sawtooth appearance, no? So this is the atrial flutter. Okay, about here, we see an irregular R to R interval. There is no definite P for every QRS. Okay, no definite P for every QRS. Very irregular R to R interval. So this is atrial flutter. Atrial fibrillation, I mean. So this is atrial fibrillation. Okay. Now, in the first ECG, you see this beat. Okay, you see a premature beat here. There is a P, but it is inverted before the QRS complex. And the QRS complex is narrow. So this bit, okay, is a premature bit that came from the AV node. So this is a junctional premature complex. How about this one? So here we see another premature bit, but the difference is, look at the P wave, okay? It is still upright, okay? It is different from the rest of the P wave. So this is a premature atrial complex. So it came from the atria. About this one, so we see a wide, bizarre looking QRS with a T that is opposite in deflection. So this is a premature ventricular complex. Okay, but this one, so we see regularly occurring PQRST. So at the rate of 300, 150, 100. So this is a normal sinus rhythm. Okay, so what do we notice? The P is normal, PR interval is normal, QRS is normal, but you notice here ST elevations. Okay, we have ST elevation V1, V2, V3, V4, V5. Okay, so this is an anterior wall ST elevation myocardial infarction. But this one, so here we see a gap, okay? And in the gap, there is a P without a QRS complex. So we know this is an second degree AV block, okay? So this is a second degree AV block. Now look at the PR interval before the drop bit and compare it with the PR interval after the drop bit. And you notice that the PR intervals are the same. So this is a second degree AV block Mobitz type 2, no? Because the PR interval are the same. Okay. But this one, we see regularly occurring QRST complex. Okay, the QRS is narrow, but there is no P. Okay, there's no P. So that means that this did not come from the SA node, okay? But you have a narrow QRS. So that means that this came from the AV node. So this is a junctional escape bit. So look at the rate, 300, 150, 100, 75, 60, 50. So this is less than 50. And your AV node will fire from 40 to 60 per minute. So this is within the firing of our AV node. So here you don't see retrograde depolarization of the atria because you don't see an inverted P just before or just after the QRS complex. Okay, but this one, we see regularly occurring P QRST, okay, but the difference is, if you will notice, the PR interval is long, no? So here, the P here started on the bold line, so the next bold line is 5 small squares, no? So this is one big square, and one big square, you know, is 0.20 seconds. So, but the PR interval is up to here. So that means that the PR interval here is prolonged, but all P's are followed by a QRST complex. So this is a first degree AV block. But this one, so here we see a gap again, okay? And within that gap, you see a P with no QRST complex. So once you see a P without a QRST complex, you know you have a second degree AV block. Now look closely, look at this PR interval and compare it with this one. Okay, this one is a lot longer than this. So that means this is a second degree AV block Mobitz type 1 or Wenckebach. But this one, so here we see regularly occurring QRST complex. The rate is 300, 150, 100, 75, 60, 50, 40, so around 30. So the rate, the ventricular rate is very slow. There is a P, but the question is it related to the QRS complex? If you notice, there are a lot of P's. This is a P, that is another P there. This is a P, okay? This is a P and another P there. P, P, and another P here. So if you notice, there are a lot of P's and the P's occur regularly. So you have regularly occurring P and the atrial rate is faster than the ventricular rate and none of the P is related to the QRS complex. So this is third degree AV block. Now about this one. So here we see PQRST, okay, the same morphology at the rate of, so if we will see here, so this is 300, 150, 100, 75. So this is around 70. So this is normal sinus rhythm. But what do you notice is you have an ST elevation in lead 1. So immediately look at AVL. So you see the same ST elevation. So you have abnormality in the lateral wall. Okay. How about lead 2? You have an ST elevation, but in lead 3 and AVF, you have a downsloping ST depression and T-wave inversion. So you have a lateral wall scheme, inferior wall ischemia here. Now, V1 is normal, but look at V2. It is very high. The ST is very high. Okay. This is a QS pattern. So this is the Q and the S merge. There's no R anymore. So this is a very deep QS pattern, meaning you have an old scar already, but you still have an ST elevation here, extending to V3 and to V4 and to V5 and to V6 and 1 AVL. So you have an anterolateral wall, ST elevation, myocardial infarction. So again, these are just reciprocal changes. So this is an anterolateral wall, ST elevation, myocardial infarction. Okay, how about this one? So here, we see a PQRST, so this is sinus, at the rate of 300, 150, 100, so around 88 beats per minute. So this is normal sinus rhythm. If you look at lead 1, the ST segment is very low, okay? It's very low, okay? Look at AVL, it is also very low, no? So you have there lateral wall ischemia. But look at lead 2, look at lead 3, and look at AVF. No, ST segment is very high. No, so this is inferior wall, ST elevation, myocardial infarction. How about V1? So V1 is still normal, but look at V2, look at V3. You have ST depression. No, in V2, V3. V4 is okay, but starting at V5, V6, you also have a ST elevation. So here, this is an inferior and a lateral wall ST elevation myocardial infarction. But this one, so here you have ST, a slight ST depression, okay, in lead 1 and AVL. So we have a lateral wall ischemia. 2, 3, and AVF are still okay, but V1, V2, V3, V4, V5 shows an ST elevation. So this is an anterior wall ST elevation myocardial infarction. Okay. Now about this one. So here, lead 1 shows you ST depression, AVL, downsloping ST depression. So you have a lateral wall here, lateral wall ischemia. But in 2, 3, and AVF, you have ST elevation. So this is an inferior wall ST elevation, myocardial infarction. But look at V1. You also have an ST elevation. In V2, you have an ST elevation. In V3 also, up to V4. So this is an anterior wall ST elevation myocardial infarction. Okay, and this one, no, maybe just reciprocal changes or no, telling you that there is concomitant lateral wall ischemia. So this is an inferior and an anterior wall ST elevation myocardial infarction. Now, in inferior wall myocardial infarction, you have to request for right-sided chest leads. Okay, so these are the right-sided chest leads, V3R and V4R. So in the right-sided chest leads, okay, here, what they did is V1, okay, V1 was placed on the other side and V2 was placed on the right side. Okay, so these are all inverted. So this is V1, V2R, V3R, and V4R. So you notice there is ST elevation, okay? So that means you have also a right ventricular infarction. So in right ventricular infarction, we do not give nitrates. Okay. Now, this is an example of a patient, a chronic kidney disease patient that missed his hemodialysis session. So what happened? The potassium went up to 8.5. So in hyperkalemia, the initial changes. Okay, I will shift to the next slide. The initial changes is a peaking, no? The T will peak. So you have peak T waves. Eventually, no, as the potassium increases further, okay, it will eventually prolong the QRS complex. Okay, so these are changes because of hyperkalemia. How about this slide? No, so this tracing, no, shows to us an irregular undulation of the baseline. There is no definite QRST complex. Okay, we just see irregular undulations of the baseline. So this is ventricular fibrillation. And again, as I mentioned, this is the number one rhythm in an arrest. Okay, and uh, in this situation, the treatment of choice is defibrillation. And we'll go to the last tracing. So what do you think is this one? So you just see a flat line. So this is called a systole. So what do you do? No, if you see this tracing, the first thing you have to check is your patient arrested? Okay, because if your patient is not arrested, then check your ECG connection. No, your ECG leads might have been detached. Okay, and if they are truly connected, as I mentioned, check vital signs and proceed with CPR. No? So the patient has to be resuscitated. So start CPR. Okay, so we do all of this. So that's it for rhythm abnormalities, ischemia, and infarction. I hope this workshop was helpful for you. Thank you very much for listening.